you to the Migraine Association for inviting me to speak. This is, I think, a very important issue, migraine in the elderly, because it can be a challenging group to treat, and also our treatment options for patients are much more limited than we would have in a younger adult population. As regards migraine in the elderly, it's a little unusual to get your first attacks, but not unheard of to get migraine in the elderly. And the other aspect of it, of course, is that patients who have had migraine throughout their earlier adult lives in their 20s and 30s. For some, it can persist into their 50s, 60s, and 70s, even though that's not the natural history of migraine for many. And we will be looking at some of those issues. But I think in the first instance, when headache does present in an elderly population, and I suppose in the context of clinical practice, anybody who presents with new onset headache over the age of 50 would be considered unusual and would require further investigation. Other aspects of a headache history that we would always look at, and particularly in this age group, would be progressively worsening headache. The other features would be early morning, always a headache, always located in the same location, prolonged aura symptoms, abnormalities in the examination, altered level of consciousness, excessive vomiting, tenderness in the blood vessels, and fever. So an accurate history is always pertinent at any stage in when you see a patient. But I think in the elderly group, the possibility of potential secondary causes goes up with age. Now, in the context of a secondary cause for headaches, there are a number of conditions, and one of the conditions, particularly in the very, let's say, elderly population, let's say in patients in their 70s and older in their 80s, a condition called giant cell arthritis, which is an inflammation of the blood vessels, is a very important condition to consider in particularly in the very elderly population, but in anybody over the age of 50, it needs to be considered. And this can be a progressively worsening headache. It's caused by inflammation of the blood vessels. It's an important condition to diagnose because undiagnosed, it can lead to blindness and strokes and obviously a permanent disability. Clearly, again, in these age groups, brain tumors, brain hemorrhages, and of course, post-traumatic headaches from falls are also conditions that need to be evaluated. So when we see a patient with headache, particularly in this elderly group, these are conditions that we, in many cases, need to rule out before we would consider the diagnosis of migraine. And that's why lots of these patients will have blood tests and brain scans and all of those kind of investigations in the routine workup. Now, as regards migraine, we are much better at diagnosing migraine now than we were in previous generations, and I think that is thanks by and large to the standardization of clinical guidelines established by the International Headache Society, which has been in existence since the 80s, but has been evolving down through the decades and is now a standard bearer for everything around diagnosis of migraine, both in Europe and the United States and across the globe, really. So in your classification of migraine, your commonest forms would be migraine without aura, migraine with aura. Less common form of migraine would be hemiplegic migraine. Chronic migraine is a complication of migraine, and it's a condition that's quite common. It's a progressive condition in many patients, and patients with migraine without aura and with aura can progress to chronic migraine, which is a condition as defined occurring on more than 15 headache days per month. Complications of migraine. And then sometimes we see patients who, or a lot of the time we see patients who would have a lot of symptoms of a migraine headache, but it doesn't quite fulfill all of the criteria. And even though it doesn't fit the diagnostic criteria for established migraine without aura or migraine with aura, we still consider the diagnosis to be probable migraine, and will often manage it the same way as we manage the actual migraine without aura, migraine with aura. So probable migraine is a blurred diagnosis, but is probably also migraine. And then there are things like episodic migraines without headaches, and abdominal migraine, which occur in younger patients. If you're looking at, the population overall and look at, how common is migraine? Well, we know that migraine occurs in 10 to 12% of the population. So the peak prevalence will be up here in patients in their 30s and 40s. And then when you get your 50s and 60s and older in the 70s and 80s, you can see that the prevalence of migraine drops off quite rapidly. However, it still does exist, and this is the cohort we're looking at this evening. So it by no means disappears in everybody, but it's a much less common condition than it would be in your 20s and 30s and 40s. Now, so as I said, overall in the general population, migraine affects 10 to 12% of the population and is 3 times more common in women. Now, if you get up into the older age group, as you can see, it becomes less and less common. It occurs in about 8.9% in aged 60 to 64. This drops down to 6.8 in age profile 65 to 69, and less common again, over 70. And as you get older and older, you can see that the likelihood of a migraine condition, it becomes less and less. And it's also noted, of course, that very few patients develop their first onset of a migraine attack over the age of 60. So most of these patients here would have had migraine in their 20s, 30s, and 40s, but it's persisted as they get older into their 60s and 70s. So irrespective of your age group, the clinical diagnosis of migraine maintains the same characteristics by and large. In order to fulfill the diagnosis of migraine with aura, then they need to have 2 attacks with the aura symptoms. The aura symptoms are what we call the premonitory or as the neurological symptoms, which usually occur before an attack but can coincide with an attack. The most common visual aura symptom will be visual, followed by sensory. They last from anything from 5 to 60 minutes, and they're completely reversible. So that's what the aura is, and this is a diagram of what a patient's visual aura will look like. And this is what we would call an expanding scotoma, is the technical term, and this often begins like here as a dot in the patient's visual field out in the periphery, and then it gets bigger and larger over time and expands, and it has a kind of a horseshoe shape or a concentric shape with a jagged outline. And this pattern can repeat over 5, 15, 20 minutes and gets bigger and bigger. And then within it, then there's this area of loss of vision or blurred vision, so that if you were looking, as let's say this person here is down a street, you would see this blob, let's say in your visual feed with a jagged outline. And this is what we call an expanding, technically we would call this an expanding scintillating scotoma, and that's the migraine aura of a visual aura. There are other aura symptoms, of course, as well, which I'll come to in a minute. And migraine without aura then is concentrating on the headache and the associated symptoms. By definition, of course, migraine is a recurrent headache disorder. So one attack doesn't establish the diagnosis, but over time, patients will have repeated attacks, which generally will last from anything from 4 to 72 hours. They're typically a one-sided headache, but not always, will be pulsating or throbbing and pounding. Patients will rate them quite high in terms of severity, moderate to severe, and they're aggravated by physical activities such as bending or stooping. Associated with the headaches then will be nausea in about 60 to 70 of patients, 60 to 70% of patients, and up to half of these patients may actually vomit. And then other symptoms will include an intolerance to light, which is photophobia, and an intolerance to sound, which is phonophobia. Now, there's a lot more to a migraine attack, and a lot of the major opinion leaders around the world look at a lot of the symptoms that are that lead you into a migraine attack, and even symptoms that occur between migraine attacks. So even prior to the aura symptoms and in the 24 hours preceding an attack, many patients will get what we call psychological symptoms such as tiredness, fatigue, and in the much used kind of current term, what we call brain fog, tiredness, yawning, loss of appetite, maybe actually an increase in appetite. And a lot of patients, when they see these symptoms and feel these symptoms, are very much aware that a migraine attack is only just around the corner. And those symptoms can occur, up to 24 hours prior to the actual headache. And then for those who get the actual visual aura, which would be this blip here, which can last, as I said, for 5 to 60 minutes with the visual aura symptoms, which occurs in about 20% of patients. And then patients get your typical migraine attack, then the headache, which is throbbing, pounding, escalates in severity, accompanying symptoms of nausea, photophobia, intolerance to light, sound, of which half of them will vomit. And then the vomiting can sometimes bring a precipitous end to an attack. And then even following the headache, many patients will have this continued tiredness and fatigue and need a continued period of rest before they would feel they have fully recovered from a specific attack. So that's what a migraine attack is like, is how patients will describe it if you explore their history in great detail and explore beyond the core symptoms of headache and intolerance to light and sound. Now, as you get older, and I was sort of focus on some of the issues that do emerge, and we do see, let's say, when I say older, I suppose it's really anybody over the age of 50, but this can occur in the 60s and the 70s, and it's more likely to occur more and more in that age group. And they're what we call late life migraine accompaniments, where the patients actually get the aura symptoms, which is, this would be this expanding scotoma, or what we call the flashing lights, the zigzag lines, which expands in the visual field, the visual aura. Then they may also get the sensory symptoms of numbness or pins and needles, which often goes down the arm and things like that. But the interesting thing is they don't get any headache with it. And that's the attack, and that can last for an hour or maybe even longer. And of course, this, when it occurs in this particular age group, requires very careful evaluation, because could it be something else? Am I having a stroke, or do I have an eyesight problem? And again, this is where these particular patients do need a careful assessment, thorough investigations, in order to rule out the potential for more sinister causes before we actually call this a late life migraine accompaniment, let's say a migraine aura without headache. And as I said, from a clinical point of view, we often have to differentiate that from is the patient having a mini stroke. And there are ways of clinically differentiating it in terms of particularly what we call the sensory symptoms, or the numbness and pins and needles. They tend to be what we call migratory, in that they move up and down the arm, and they will vary from being a numbness to a pins and needles, where if you're having a mini stroke, it will be kind of a very sudden, abrupt onset, and it doesn't really move up and down the arm. It just sits there and is there. But again, it needs a careful evaluation, and these patients would be carefully evaluated in stroke units, and you often end up with migraine patients in a stroke unit because there's concern about what the diagnosis actually is. Now, so in terms of other things that you need to consider, for example, if patients are just getting the visual aura symptom on its own, which, as I said here, the jagged outline, which gets bigger and bigger with an area of loss of vision, retinal detachment is an extremely important condition to consider, particularly in anybody really over the age of 50. But again, it's not uncommon in patients over the age of 60, and patients who present with symptoms like this for the first time. We would not start out by causing this migraine. We would send them to an eye specialist to have a look at the back of the eye to see are they actually having a retinal detachment, and other eye conditions that can maybe mimic a late life migraine accompaniment as well would be glaucoma. So this is where, as you can see, assessing and evaluating migraine patients in the elderly is quite complex. It needs a lot of careful history taking and relevant investigations with eye departments and neuroimaging. Again, one of the other risks of as you get older is that patients progress from episodic migraine attacks where, you know, in my 20s and 30s and 40s, maybe I was getting 1 or 2 migraine attacks per month. But as I got older, my headaches tended to last longer. They were more frequent, and I was getting less headache-free days, so that the insidious develop what we call chronic migraine, which is more than 15 headache days per month, of which half of those headache days would be very typical of my previous migraine attacks, let's say of being a one-sided headache, throbbing, pounding, nausea, intolerance to light. So the risk of progression to migraine increases with increasing age. Other risk factors, let's say in your past history of migraine, would if you had a relatively frequent number of migraine attacks. Anyhow, women are more at risk. And other morbid conditions can put you at risk as well, such as being overweight, or psychological conditions such as anxiety or depression. Now, so just to touch base on, you know, what is migraine? You know, it's not, as they say, the euphemism of it's not just a headache, which we all know it's not just. But we do, it's a neurological disorder. It's the commonest of the neurological disorders. We have a much greater understanding of what's going on during a migraine attack now over the last few decades. And of course, obviously the research that's emerged in the last decade or so has enabled new therapeutic targets and new medications to be developed. So in terms of a migraine attack, your pain sensitive structure will be, this is the coverings of your brain. Let's say this is your skin, this is your skull, this is just inside your skull, which is what we call the subarachnoid space. These are your meninges, the coverings of the brain, and these are the blood vessels in what we call the subarachnoid space. And these are what we call rich in pain sensitive innervation, and the pain sensitive nerve which transmits pain from these structures in the head is a nerve called the trigeminal nerve. So that's how pain is transmitted. So this is where your pain sensitive nerve, which transmits pain from your pain sensitive structures, which be the meninges themselves here, and also the meningeal blood vessels here. So these are the pathways, these are the structures that cause a migraine headache, and this is the pathway in which pain is transmitted along the trigeminal nerve. But prior to the headache itself, we also get, you know, as we discussed, our outlined was the aura symptoms, let's say, of the flashing lights, the zigzag lines, the blur, the area of loss of vision. And what's happening there is you're getting an area of the brain in the back of the head here called the occipital cortex. And then you're getting electrical activity in this area of the brain, which is responsible for vision. And that causes local changes in this area of the brain and altered blood vessels and transmission of what we call an electrical wave across the surface of the brain. And that allows the emergence then of your aura symptoms, such as the blurred vision, the jagged outline, the area of loss of vision, which expands over time, may be accompanied by the sensory symptoms of numbness or pins and needles. So that's the explanation for the aura symptom, which is separate from the headache. So coming back then, the next phase of the headache, so your pain sensitive structures, as I said, would be, for example, here, this would be the blood vessel or the coverings of the brain itself. And during a migraine attack, we know that you're getting the release of these chemicals, and C.G.R.P, which stands for calcitonin gene related peptide, that's what it stands for, and other neuropeptides are also released. But this one is the one that's has been really in the news over the last number of years because of what's been happening around medications. And these peptides are released at the onset of a migraine attack, and when they're released from the nerve supply, which is the trigeminal nerve, and they're released into the area between the nerve and the blood vessel, and that then is responsible for setting up an irritating, painful pathway on the blood, from the blood vessel itself, and then painful, sensitive information is passed in along the trigeminal nerve into the brain, where it has a junction with other nerves, and then it's onward up to the higher centers in the brain, where we perceive pain. And that's what's going on during a migraine attack. As I said, it's a neurological condition. And that's what we call the trigeminal vascular theory of migraine, which is the recognized pathophysiology of a migraine attack, and well documented now for a number of decades. I thought I would touch on the MRI scans that we end up doing on migraine patients. And I suppose one of the reasons I decided to include this in the talk is because, you know, in this case, anybody heard it, or we did an interview with on the Pat Kenny show last week, and one of the interesting things is that Pat asked me about MRI scans, and in his question, he told me that there was no difference between an MRI scan of the brain in a young healthy adult and an adult who has migraine. And of course that is actually incorrect, because, and we had a discussion around that. So I thought I would include it in tonight's talk, because these changes that you see on the MRI scans are more commonly seen as you get older. And of course, I think it's important to address them, because people obviously, it can cause concern. But just to have a look at them first, okay? So this will, let's say, be, for example, a healthy brain, let's say of a 20-year-old, and you can see there's a difference here from an MRI scan of an adult migraine patient as you get older. And you can see what's here is these white dots, and we call these things white matter abnormalities or hypersensitivities, which are seen in many areas of the brain in patients who suffer from migraine. And sometimes we see these conditions, these changes in other conditions, but are commonly seen in migraine. So the first and most important question that obviously a patient will ask, and be understandably, you know, what does all this mean? I think, first of all, they're of no clinical significance in any of the literature that's been researched around all these changes that have been found in MRI scans in migraine patients. We do know that these number of lesions increase as you increase with age without causing any clinical significance. I think an obvious question that people do ask, and an understandable one, is that these lesions do not cause any cognitive decline. These lesions do not put you at risk of getting dementia or Alzheimer's disease. And I think that's probably one of the clear messages to understand, that the MRI scan changes that we see in migraine haven't been shown to demonstrate any illness in terms of any other neurological conditions. So why do you get them, those? Which is again a scientific question. You know, why do you? We accept that they're of no clinical significance, but they are a very interesting scientific observation in that, you know, well, why do I get them anyhow? So what's causing them? And as we understand it, and the theories behind that, because migraine is a neurovascular condition, it causes vascular and inflammatory changes around the blood vessels and the nerve supplies that are adjacent to these blood vessels. And it's felt that each repeated, because migraine is a recurrent repeated attacks, that it may cause inflammatory changes which are accumulative over time, and ultimately leading to these white matter abnormalities that we observe on the MRI scanning. But again, I'd like to emphasize that they don't cause any complications, and they do not cause any clinical significance in their own right. In terms of management of migraine, irrespective of your age, whether you're a 20-year-old or you're a 70-year-old or older, the guiding principles remain the same: education and advice around the nature of the condition, the use of headache diaries on the basis that it's a recurrent condition. Each attack, you know, it should be documented on its own merits, looking for factors that may have contributed to any individual's attack, trying to identify and then obviously avoiding any trigger factors that may be relevant, and then looking at the role of acute therapies and preventative therapies, and obviously other non-drug approaches such as vagal nerve stimulators, trigeminal stimulators, they're also out there. And then non-drug approaches, of course, in terms of exercise, relaxation techniques, acupuncture, etc. All of these have a role in migraine management, and for individuals, many of these things, have a preferred option depending on the response to different approaches over time. And the headache diaries will often guide you as to how best to manage and where is appropriate for each of these treatment options at different times. Now, in terms of trigger factors, again, they're the common ones. In terms of diet, cheese, chocolate, all of these things are relevant. Again, we don't ask people to give up anything in terms of their diet if they suffer from migraine, unless they, with the aid of their diary, recognize that this brings on a migraine attack. Two other things in your diet, of course, which are implicated in triggering migraine attacks, are alcohol, particularly red wine, but any alcohol can do it. And it is a common enough trigger, actually, alcohol. Caffeine is another very important trigger, and people insidiously, can be quite dependent on coffee, and can drink up to, often start out in the morning with the first thing with a cup of coffee, would have a number of cups of coffee during the day. It's been a lifestyle that's been this well established, and they know that if I don't have a cup of coffee within a certain period of time, I'm going to feel my headaches coming on. So sometimes patients will have to go through withdrawal from coffee because there is a little bit of a dependency syndrome around caffeine. So caffeine is quite an important trigger for many patients. Stress is probably the most uncommon trigger for migraine. And again, what I emphasize again in terms of stress is not the cause of your migraine. Stress is the thing that triggers it at vulnerable times for individuals. And often it can be what we call a period of relaxation after a busy schedule or a working week, or just a busy day at home, or change of routine. All of these have the potential to trigger attacks, and then managing that and being good with your time management is a key component of looking at, all of my approaches to managing migraine and making me less vulnerable towards an attack. Interesting, as you get older, it's been observed that as regards trigger factors, bright light, sunlight, and fluorescing lighting becomes a more important trigger, in patients over the age of 60 than it would have had in the same group of patients who in their younger adult life, 20s or 30s, as a trigger factor. So in this group, it is more relevant to them in terms of being a potential trigger. Again, vigorous exercise is an important trigger, whilst mild to moderate exercise is a treatment modality that we've touched on in the last slide. Head injury is an important trigger for migraine, although technically we would call that post-traumatic headaches rather than being migraine itself. Lifestyle things, then obviously missed meals, tiredness, lack of sleep. These are all either physiological or psychological stressors to your system, which can predispose you to an attack. Strong odors are also important. So with the aid of a diary, just looking at all of that stuff, that can enable you to reduce your frequency as well. It's not your cure for migraine, but it can minimize the number of attacks that you get. So these are your treatment options, both as acute therapies and preventative therapies in what was conventional management up to recent times. And of course, in the acute list, there are a group of drugs here called the triptans, which many of you may be familiar with, and they're only licensed for adults aged between 18 and 65 years of age. And even in that age group, there are precautions around using them in terms of whether you've got a high blood pressure or coronary artery disease and other conditions. So we are limited in the old elderly, and particularly in the very elderly groups, in not being able to use these drugs, particularly if you've got a diagnosis of coronary artery disease. Now, if you don't have coronary artery disease, some doctors will prescribe them, in discussion with the patients, as they are very effective drugs in all age groups, but they are particularly contraindicated in patients with coronary artery disease. So that brings us back then to our limitations of, simple analgesics such as paracetamol or ibuprofen, and also the use of codeine products, which have their own cautions. And again, the use of anti-inflammatory drugs are also with caution, because it's felt again in the older populations this puts the patients at risk of stroke, and therefore one has to be very cautious about using any of these drugs for migraine. We do continue to use, of course, anti-nausea drugs in terms of domperidone for the nausea. And this is your group of conventional preventative drugs that are available, the beta blockers, topiramate, pazopanib, flunarizine, amitriptyline, and botulinum toxin. All of these drugs many of these drugs have been available for generations, and they do have quite an efficacious role for the management of many migraine patients. And you need to explore these preventative drugs with the patient, again, and looking at their comorbidities, and also making sure that there's a reasonable period of time on these medications before their efficacy is evaluated. Again, I'm going to go into this a little bit deeper now, in the sense that when you do look for an acute drug, let's say whether it's paracetamol or whether it's ibuprofen, or whether it's a paracetamol codeine preparation, it's most likely to be effective if you take it early in the attack. And then ideally you would like to get relief from the associated symptoms, and it keeps you free of side effects. So it's important to take your medication, irrespective of which you choose, early in the attack, rather than letting the migraine attack establish itself and waiting to reach a point when you feel you need to take something. When you do that, it's much less likely to be effective, and you may have missed the opportunity to treat an attack, even with a simple analgesic like paracetamol. You need to limit the use of these medications to 2 to 3 days a week of acute therapies, again, because of the risk of getting what we call medication overuse, where there's an interaction or feedback from the overuse of medication to it likely to cause relapse into your next attack. And that is a risk if you're taking any kind of an analgesic on more than 2 to 3 days per week. And again, the analgesics of choice in the elderly would be paracetamol, ibuprofen in low dose, or soluble aspirin. Again, as outlined, there is huge caution with paracetamol codeine preparation because of the risk of what we call habituation, dependence, and tolerance, and the subsequent development of medication overuse with the use of codeine preparations. And again, as I've outlined, the triptans are really not licensed over the age of 65. However, they are often used in healthy adults in that age group if they don't have established heart disease. However, that does need to be in consultation with the patient, and evaluating any risk of taking a medication against the benefit of what may have been a very efficacious and effective treatment for that patient's migraine down to the years. And again, in this age group, because other conditions are becoming more common, particularly high blood pressure and uncontrolled hypertension. High blood pressure would also be very much a contraindication to the use of the triptan therapies. So when do you use a preventative drug for migraine? There are a number of guidelines there now, but we would consider the use of a preventative drug if the patient has 4 or more migraine days per month, or if any individual attack is quite prolonged and lasts for longer than 72 hours. Patients who are very poor responders to the simple acute therapies, or for those, in that matter, for whom the triptans, as I've been discussing, are contraindicated, and for whom acute therapies are really not very helpful. Patients who can't tolerate acute therapies, and patients who then have prolonged aura symptoms, let's say of the visual aura or the sensory paresthesias. And again, if when you do choose a preventative therapy for migraine, it's important that the patient takes the preventative drug for 3 months before you sit back and look at your diary and make a judgment as to how beneficial that particular medication has been for the past 3 months. And that's important because the benefits of a preventative drug tend to be cumulative, and often don't kick in until a month or two has passed. And therefore you may miss an opportunity to use a preventative therapy if you dismiss it too quickly after being prescribed it. And again, the other cautious thing about prescribing preventative drugs in the elderly is because of the other morbid conditions that individuals in this age group are developing, such as high blood pressure, diabetes, depression, cardiovascular disease, arthritis, epilepsy, and cancer treatments. And therefore, there are a lot of potential drug-drug interactions between what you might be on for any one of these conditions and any drug you might be potentially considering as a migraine prevention for your migraine. So again, one has to be careful about what you choose and be careful that there aren't potential complications such as serious drug interactions with the medication that you're on for another condition. At the same time, though, one could also say that because the conventional drugs like beta blockers or topiramate or antidepressants or another antihypertensive agents, a lot of these drugs here were developed initially for other conditions. Beta blockers were primarily developed for hypertension. Topiramate was primarily developed for epilepsy. Tricyclic antidepressants were primarily developed for depression. Candesartan is an antihypertensive drug. So sometimes if you have what we call comorbidity, that if you do have some hypertension, then you may find that the beta blocker that you choose to manage your migraine may also just as equally be beneficial for your high blood pressure. Equally, if you've got a history of seizures, then topiramate is a drug that could manage both conditions. And also one of the latest hypertensive ones that we use is candesartan, which is a very effective drug as a migraine preventative therapy, but also can manage that patient's high blood pressure. So in many ways, you can treat, as they say, kill two birds with the one stone with some of the medications. But that's the positive side of choosing a conventional preventative therapy when you look at the other morbid conditions that a patient may have as you're likely to get as you get older. So this leads me into where are we today and where are we going for everybody, not just older people, but and again, I'm sure we're all aware, and certainly the Migraine Association is, and so many of you will be, of the new treatments, the C.G.R.P monoclonal antibody antagonists for migraine prevention. Just to say, how do they do it? How do they prevent migraine? Again, coming back to the theory of migraine, again, this would represent the trigeminal nerve. And this innervates and is the nerve supply, let's say, and this would be the covering of a blood vessel here, like the meningeal vessel. So again, during the migraine attack, this is the release of the C.G.R.P out into the area between the nerve and the blood vessel. And it can also, as you can see, attach onto the blood vessel down here. And that's what's going on during a migraine attack. When you take the monoclonal antibodies, and what these do, they block the actions of these drugs, and they don't all work the same. But drugs like this one here, fremanezumab, galcanezumab, and eptinezumab, they block the actions of C.G.R.P by attaching here to the C.G.R.P, which has been released between the nerve and the blood vessel, whilst this first one, erenumab, attaches itself to the blood vessel itself on the receptor site on the blood vessel here. So they work a bit differently. And of course, by blocking the actions of C.G.R.P, and they have a long half-life, they often and frequently are very effective in reducing the frequency and number of migraine headache days per month. Now, unfortunately, in Ireland, as you can see, I have outlined it and highlighted in bold, these are only licensed and reimbursed for patients up to the age of 65. There are other jurisdictions in Europe where they are available in older age groups. Hopefully this may potentially change over time. This is the licensing protocols that the HSE have insisted upon in terms of the use of these medications, and they're only licensed up to the age of 65. Therefore, in terms of migraine prevention in patients in this age group and older, we're still limited to the conventional migraine preventative therapies, which I've discussed in previous slides. There is some good news coming, though, in terms of more treatment options, and that's what we call this, the small molecule C.G.R.P antagonists called gepants. So they're different from the monoclonal antibodies and that they're tablet formulation, number one, so they're oral medications, whilst on the previous slide, which I just show you, all these are given by injection, subcutaneously, or this one intravenously. But in terms of these new medications that are not here yet, but are on the horizon, they're oral medications, and they work differently from the monoclonal antibodies in that they're taken orally. They're what we call small molecule gepants. They work on the receptor site on the blood vessel here. So they have what we call a high affinity, and they attach to the receptor on the blood vessels itself. Now, what is absolutely fascinating about these drugs is that they have both a license to be taken as an acute drug when you get an attack, and you can also take it potentially as a preventative drug, and I'll touch on that in a second. But as they say, there is going to be, as they say, I wouldn't call it a friendly war, but there will be a war coming as to who's going to win out the battles. And maybe it isn't a question of winning out, because I think all of these medications will be suitable for different patient groups, depending on efficacy and patient preference and personal choices between the monoclonal antibodies such as erenumab, fremanezumab, galcanezumab, and these newer agents, the small molecule tablet forms like rimegepant and atogepant, which are not here yet, but these tablets, these medications will be taken orally. But what's fascinating about these drugs is one thing, is that just recently, and this is the first one, is that last week, this is the European Medicines Agency in Europe, which is the licensing authority across the European Union, which has got 27 members. And this has just been approved as a medication that you can take both as an acute drug and a preventative drug for your migraine. It's almost, is that the ideal way you'd like to manage your migraine? I think there are many opinion leaders say it is. I mean, I'd love to be able to take a drug that when I get a migraine attack, it'll give me relief. And then hopefully it will also, maybe I can take another tablet maybe tomorrow or the day after as a preventative drug to prevent future attacks occurring. And this is what this drug has been licensed for at the moment. So the way it will be prescribed is that you take it when you get an acute attack. And then if you want to, you can take it every second day or up to 18 doses per month to try and keep away any potential attacks which occur. And the clinical trials on this have been very encouraging. And I think they will be a huge, exciting medication that we'll have in our armamentarium to manage migraine going forward. And I've looked at the data on this. This is not limited to any age group. This is licensed on the European Medicines application for adults over the age of 18, and it doesn't have a limiting age on it. So the future is good in terms of potential treatment options, in terms of the small molecule gepants. As I said, it's just been licensed in the European Medicines Agency. That doesn't mean it's available. That just means they've approved it as a safe, effective treatment for migraine. It's now up to each individual country within the EU, and in Ireland, that's the HSE, to negotiate with the drug company a price and a reimbursement and who will be eligible to prescribe it, whether it's in general practice or hospitals or neurology department or headache clinics. So I would like to end on a positive note and saying that the future is looking very good, I think, for all migraine patients, for what is continuing to be a disabling condition. And as Pascal will tell you, the Migraine Association is the third leading cause of disability in terms of healthcare conditions. And I think that completes my slides. Thank you very much.